Alrighty, so thank you again. And we're going to begin with our presentation with our two speakers. But before we do, please know that if you're unaware about the SIG, we are part of the RSNA, and our mission is to promote the highest quality of 3D printing in medicine through education and collaboration and research. And we remind all of our members to renew their membership. Sometimes that drops at the end of the year and it does not auto-renew. So check your status and join or renew if you haven't done so already. We want to highlight our subcommittees. We have four: the education, the appropriateness, and the quality assurance and outreach subcommittees. They have been quite active this past year. And in particular, the education subcommittee was tagged to contribute to our upcoming activity, which is our CME meeting coming up in April. Please remember, you can go online and check out our program. We are going to have the opportunity for in-person subcommittee meetings as well as networking. And for the first time since the RSNA of 2017, we shall have a hands-on session and more. So for that hands-on session, you will have to bring on your own device, and you will find more details as we get closer to the time of our meeting. A little bit on the themes that will be covered during that meeting here presented. And so you can, again, go online and check out our program. Without further ado, I want to thank you for joining us today and start with our first speaker, Shayne Kondor.
Good afternoon. I am Shayne Kondor from University of Cincinnati, College of Medicine, Radiology Department, 3D Printing Lab. And I'm going to talk about some of our experience in 3D printing for underserved populations in the Midwest. If you check on PubMed about 3D printing for medically underserved populations and areas, you're going to not get much. Looking for underserved populations, you're going to get 3 results. If you search on 3D printing in medically unserved areas, you're going to get 0 results. So this is a field that's somewhat being ignored out there right now. FEMA in the US government defines an underserved population or community as socioeconomically disadvantaged, limited proficiency in English, geographically isolated, possibly people of color or ethnic minorities, women and children, individuals with disabilities, and seniors. The definition from the Department of Health and Human Services is a little different. It includes the rural elderly, low literacy, and it also looks at medically underserved areas and populations where there are too few primary care providers, high infant mortality, high poverty, and a high elderly population. And this is something we see in the Cincinnati area. There's a slight difference between what we might call a medically served area and a underserved population. So an area is looking at this geographically. The Department of Health and Human Services will look at an entire county, a group of neighboring counties, census tracts, whereas in an underserved population, it may be more a general group, homeless people spread across a region, low income, Native Americans, which we'll touch on in the presentation, migrant farm workers, and people who are Medicaid eligible. So the University of Cincinnati is a ACS Level 1 verified trauma center, and we're the regional safety net hospital in the Tri-County or Tri-State region of Ohio, Kentucky, and Indiana. Here's a map showing Cincinnati at the center. You see Medical Center is approximately at the dead center of this map, and the color coding in the map is income, red being low income, green being higher income, yellow being median. And you'll see a lot of red right around the word Cincinnati on this map and stretching out to the east and west of Cincinnati and much to the north of Cincinnati, there is great poverty. If we look at the tri-state and medically unserved areas, and this is looking at all of those aspects, we'll break it up into information from Ohio, Kentucky, Indiana, and you can see these shaded counties and areas in gray, especially in dark gray, are critically underserved areas. And if you pull those three states together, University of Cincinnati Medical Center is right smack in the middle. We're the regional trauma center with facial trauma training for OMS surgeons, ENT surgeons, and plastic surgeons. So I'm going to take a slice of data out of our traumatic mandible fracture trial that's ongoing. Now, I'm going to give you a glimpse of what we're doing here. We're making models, 3D printed models for pre-bending fixation plates. We're conducting a trial, and this is a trial with control to prove the efficacy of using 3D printed model for pre-bending fixation plate in cases of traumatic mandible fracture. To date, we have produced 15 models. There have been about 36 patients that have been consented into the study. Most have turned out to go into the control group. There have been 2 cancellations. And I'm going to take a slice of data out of this group to show you what we're contending with in UCMC. Just a quick review of what we're doing here for those who may not be completely familiar. We'll start out by segmenting the fractured mandible, modeling it in CAD, reducing that fracture digitally, perfecting that mandible. So now we have the mandible fragments back in proper location, giving the patient the best occlusion. And from that, we'll 3D print a final model. Now, this study so far, looking at the insurance coverage of the enrolled subjects, 40% have private insurance, but 60% fall into a category where we're not hopeful of seeing insurance reimbursement. That's 20% who are uninsured, 20% who have Medicaid coverage, and 20% on Medicare coverage. And currently, Center for Medicare Studies is not allowing payment for category 3 codes like we are charging. Some of the private insurance companies are paying under these codes, but we're seeing a low net return on this. Now, how does this break down amongst our population areas? Well, amongst our Medicare population, it's an even split between rural medically underserved areas, non-rural medically underserved areas, that being the urban areas in and around Cincinnati, and non-medically underserved areas. There are some areas, as you saw on the map, that have above average and average income. Amongst our Medicaid patients, over 2/3 of them are coming out of the non-rural, so the urban medically underserved areas, and a few from the non-medically underserved areas. Amongst the underinsured patients, it's the same proportion, about 2/3 from the urban, non-rural, medically underserved areas in and around the city of Cincinnati. And amongst our private insurance fraction, we see that it is, again, about 2/3 coming from the non-rural medically underserved areas. And then amongst that, about 1/6 from the rural areas and 1/6 from the non-medically underserved area. I actually would have expected that we would be seeing more out of the rural medically underserved areas since they seem to surround University of Cincinnati, but we're drawing from the urban areas. this was recently published. A lot of y'all may have read this paper already. It's the University of Cincinnati 3D first year experience on our cost. It was published just last year. We had an average lab cost, taking everything into account across all the models made, of about $2,731 per model. The estimated savings to the hospital in operating room time saved across the models polled was $2,900. So we were showing that we were about break even to the hospital in overall costs, but the insurance reimbursement rate and charging under the Category 3 codes was very low. Anecdotally, we're told it's under 30%, although I don't have real data from our administration to show on this. But we know we're under a lot of cost pressure right now because we're unable to recoup payment for most of the models that are being made. And as we know, we can show a savings to the hospital and saved operating room time and such, but still, the 3D printing lab is looked at as this large cost since the models are about equaling the savings. It's very, very hard to justify ourselves. Now, there are other areas where there are no 3D printing services available for the most part. And one of the areas that we found this to be true is amongst the Native American health centers. I could find no evidence of a 3D printing capability among the Native American health centers and the Indian Health Service. And we had been approached by Alaska Native Medical Center to make a very complex orthopedic model. Now, this model probably far exceeds that average cost of $2,731 per model. I would guess probably more in the $7,000 to $8,000 range. It was a patient with a complex fracture of the pelvis with a malunion. They were in a coma for quite a while. The surgeons at Alaska Native Medical Center wished to study the model to see what they might be able to do for this patient in a revision surgery to correct some of the issues. You can see the model here in CAD. The affected areas have been highlighted in pink, and heterotopic ossification nodules are highlighted in red, and these were free floating. And we built these into the model on clear struts coming off of the bone. We started out from, of course, DICOM data sent to us from Alaska Native Medical Center. We performed the segmentation CAD modeling and 3D printing. And then the model was shipped by FedEx back to Alaska Native Medical Center. It consists of 6 parts that were printed in groups on 3 parallel prints on PolyJet and VAT polymerization printers, and it was assembled using steel dowel pins since we did not have a single printer that could handle this particular model in one build at the time. Show the groups assembled here, and this is the model that was displayed in the RSNA SIG 3D printing showcase of this past 2013 meeting. Now, so that brings me to the end of my short presentation on this. The experience is that we are in a fairly economically disadvantaged area, and the lab is struggling to recoup costs and keep itself afloat. That's the lesson learned. I don't think until we have the Category 1 codes and can actually bill on those Medicare and Medicaid patients and recoup some degree of reimbursement, it's going to be a proposition of trying to convince our hospital that we're sort of a break-even proposition. Okay. And I'll turn it on over to Dr. Gomez Martinez.
I'm sorry, I had the mute. So again, my name is Pedro Gomez. Thank you for having me. I'm radiologist at Hospital Escuela Universitario and faculty member of Universidad Nacional Autónoma de Honduras. So here we're going to talk about 3D printing in medicine in Honduras. So we're near lunchtime, so I have this quote from Roger von Weck, who says, "Life is like cooking. It all depends on what you add and how you mix it. Sometimes you follow the recipe and other times you're creative." Uh, this is a map for those who might not know where Honduras is located. We're at the heart of Central America. It's a country with an estimated population of around 9 million people, with a life expectancy of 77 years approximately. It's the economy number 104, and the development index ranks number 132. Around 70% of households live in poverty, and 53% live in extreme poverty. Around 87% are not covered by any health insurance. Even the rest of the population has some sort of insurance. At the hospital of the National Institute for Social Security, there were performed around 4,500 surgeries in 2022. Some of them were from orthopedic, neurosurgery, plastic surgery, and maxillofacial, bringing around 52% of them. Another data that I would like to share about Honduras is that is the fourth ranked in global export of coffee. Here I have a picture of my hometown, Tegucigalpa, Honduras, which is the capital city, where I was enjoying a nice cup of coffee. So you might as well have a coffee from Honduras. Our university is ranked as of 2023, was the #1 ranked in the ranking, in the CIMAGO ranking, was the #1 in Central America. So a little about the experience that we had in 3D printing. This journey started back in December 2021, when during the pandemic, we had to virtually attend some of the courses, and thankfully the RSNA allows us to join the annual meeting through virtually. So this was the first time I was encountered with 3D printing. This was a course back in December 21st, 2021, done by Dr. Nicole Wake, Amy Alexander, Sarah Remini, and Peter. Right after this, we went to Chicago to trying to learn a bit more about 3D printing back in April 2022. We also attended some of the webinars throughout the 3D Printing SIG Learning Center. And this was a webinar done by Dr. Morris about the intersection of art and medical 3D printing back in September 2022. After that, my colleague, Dr. Blanca Aleman, joined this effort in trying to bring 3D printing for a reality in Honduras. We started the talks. The dean of our School of Medicine was very open and shared as a place in the SIM lab. I'll show you in this video where it's located. We had this small space with a desk, but it was enough for us to start in this lab. Soon after that, we started printing using economical 3D printers such as the Anycubic Photon M3, which we bought through Amazon. We had some exposure to the media. Our faculty gave us an interview. As well, we were at this program, Frente a Frente, is like the most renowned space on TV in the Honduras television. And we were able to talk a little bit more about the innovation in the health sector. Here are some pictures that were published. This is a video of us doing some 3D printing of our patients. So we are able to do 3D printing at low cost. And it's worth of notice that we run with all the costs through this first moment. This was our first model that we printed out of a patient who had underwent maxillary resection due to cancer. The maxillofacial surgeon wanted to have this model to be tried on first before having to make this implant made in titanium, because we don't have this here in Honduras. So they have to make it in Spain and import, and it's very expensive. So he wanted to try if it would fit first on the 3D printed model so he could after ask for the titanium plate. These are the results of the surgery. You can see the defect on her face and that it was corrected afterwards. Another patient, this is a female patient, a 19-year-old who had facial trauma with fracture on the right orbit. The 3D printed model of her allowed the surgeon to model the plate that was going to be inserted soon after. So he told us from his experience that he saved around 30 minutes in OR time. Another patient with a humeral head fracture, and how the 3D printed model helped out in the surgery. This was a patient that was presented at the RSNA. This is a male patient with a gunshot wound at the mandible. You can see here where the defect is, and we use the mirror model for him to model the plate that was going to be replaced. This is a video showing how we use the good section of the mandible to recreate a fictional one for it to be printed out without the defects. This is the actual surgery. He also had allowing hurt from the iliac crest bone to fix the problem. This is another patient, a male patient around 38 years old, who had a car accident. He had a femur fracture. It was around 12 fragments of the bone. You can see there, it's like a puzzle. So the good news for the orthopedic surgeon is that he could try on the 3D printed model first, how he was going to be able to reconstruct these fractures. This is another patient, a 15-year-old girl with an osteosarcoma of the left femur. And we printed out this model based off the CT scan so that the orthopedic surgeon could show his residents the actual bone tumor. And this is through a donation, this patient received this implant and the extremity could be saved because she was destined to be amputated. After that, we received a scholarship. We won the first place for the National Secretary of Science and Technology and Innovation, where this allowed us to go to the RSNA and present. This is the Center for Art and Culture from our university. It has a historic resemblance, since in 1969, this is where the School of Medicine lived. Throughout this day, there is an art exhibition showcasing the evolution of medicine in Honduras, and we're proud to present a piece of our models in the museum. So we are really honored by this. You can see the exhibition, and at the right side of the image, well, you can see the 3D printed model. That is being showcased right next to a very old book of anatomy. This was our last day as residents, and many of our mentors who have accompanied us throughout the years and making this a reality. So I'd like to end with a quote from Pablo Picasso, who said, "It took me 4 years to paint like Raphael, but a lifetime to paint like a child." So you can see how we have evolved from being like a picture from Da Vinci, and now we are able to study anatomy through virtual VR and AR. And finally, this is a picture from the oldest working clock in all America. It's located in Comayagua, Honduras. And well, I invite you, if you're interested in antiques, well, you might as well come to Honduras and visit this place. Thank you.
Thank you so much. Thank you, both Dr. Gomez and Shayne. Excellent presentations. And right now we would like to open up the floor for your questions. And you can type those in the Q&A so that we can engage in some discussion. I would like to start with Shayne. You mentioned that you are conducting a trial at this moment. How are you guys able to fund and pursue this trial?
The trial is being funded through the oral maxillofacial surgery department, the otolaryngology department, and plastic surgery department together in their resident training. The leader, the PI for the project, is the chair of oral maxillofacial surgery. So he was able to secure funding internal to the hospital for this particular study.
And you mentioned a little bit about measuring OR time. Is that one of your main outcomes?
We have been tracking it as part of our data for the ACR 3D printing registry.
Mhm.
So that will be, in the end, when the study is finished, part of the tracked outcomes.
Mhm.
The idea of going back and actually looking at the insurance status of the patient came up with this presentation. Hadn't actually thought about doing that until this subject was suggested. And when I went out looking around to see if there were any literature, search, reviews, anything to speak on in the beginning of the introduction, and couldn't find anything, I'm like, wow, this is something that really hasn't been addressed. How are we, providing equity to medically underserved populations in 3D printing, since we know pretty much we're not going to we're not guaranteed of insurance reimbursement, we're probably not going to be paid. So the trial I thought was a good slice of data, since there was no requirement for the model to be paid for in the trial, and see what type of patients are we getting across the board in our area. And it gave us a good cross section of the area, as well as the level 1 regional trauma center. We were drawing from both urban and rural counties surrounding Cincinnati, and that you saw in that mix of medically underserved areas as well as income. There are wide discrepancies throughout the area.
Yes. And the reason why I'm asking is, as I saw your focus on OR times, Pedro, you also mentioned that your surgeons are commenting almost as a immediate impact is their ability to also decrease their operating time in the cases that you showed. Have you had any additional feedback beyond the decrease in OR times as you guys engage in 3D printing in Honduras?
Yes, we had some feedback from different surgeons who told us, for example, the one of the femur fracture, they reduced around 2 hours of OR time. And the patient who had the orbital fracture decreased around 30 to 40 minutes of OR time. Yeah.
And I think these are common things and things that obviously we are trying to capture in our 3D printing registry. I think, we can see that experience, whether it's Honduras, whether it's the most established lab in the US, whether you're doing it, for an underserved population. The other question that I have is, you showed the case of the femur fracture, and in any other circumstance that would have led to an amputation. And I think you mentioned that the patient is quite young, 38.
Yeah.
So the thing that I think would be interesting, although probably very difficult, would be to capture the downstream effect of what would be the standard care if there is no 3D printing. So very much to what you guys are structuring in your trial, Shayne, in terms of a control group, but almost doing it virtual, right? Take a patient, yes, you engage in the 3D printing model. In that case, they were able to do a surgical approach to preserve the limb. If there was no model, then that would have meant amputation, which would have meant, dysfunction, making a prosthetic device, however many months of physical therapy, maybe retraining, and all of the complications that come with the loss of a limb. And I think these are areas that we are not capturing definitely not within our registry, right? Because this is really downstream type of benefits. So I think it would be interesting to go back to our administrators, especially as we're continuing our CP3 code with the hopes of extending into a category 1, is how do we not just get that immediate OR benefit, but also demonstrate this longer term change in management. I think especially in underserved areas, that will really show the impact of what we're doing, because it goes beyond that immediate phase of care, that acute phase of care where the model has been produced, and into the longer impact into patients' lives. So I guess the biggest question is, how, under these very difficult circumstances, right, where I see Dr. Pedro is sitting by the scanner, trying to be the student, take call, you know, take care of the patient, let's establish the lab and learn. But how do you then follow these patients long-term, or how do you track? And do you feel that your administration, the hospital administration, or even in your case, as you got your award, would the Secretary of Health provide some support to track these results? Does that make sense?
Yeah, so to start off, we don't have any type of registry. So since we're just having the building blocks of this starting, we are really new to this. We don't have that much of experience, but we obviously throughout the time we hope that we can have this type of to have the evidence to support the how 3D printing is going to change lives. So yeah, definitely we're in the midst of trying to get some more people to know what we're doing, how this can help the patients, how this can help the institutions to lower costs, how this can help students to learn, how this can help the patient to understand their pathology. And we are trying to make that sort of connections with the decision-making people to get to know what we're doing, and eventually we can get some support from them.
So again, if you guys have any questions in the audience, you can put them in the Q&A component or in the chat. And I have another couple of questions. So a lot of the cases that you showed had to do with bone, like the orbital fracture. Are you seeing that basically from the surgeons requesting? Is that kind of the driver?
Actually, it was for convenience, since we're just starting. It's I think it was like an easier approach to start off by doing just bones, since it's easier and we can build an experience from that and to extrapolate that next to more complex situations. But as of this moment, we have very lots of limitations. So we are just starting. So we decided that bones would be like the first approach.
And thinking of longevity, you were a resident, now you're attending faculty.
Yeah.
Do you see more people in training getting interested? And do you see the longevity of 3D printing being integrated into your training and the future training of radiologists? And
Yeah, sure, certainly. Yeah, we have some conversation with other residents from different specialties, and they were amazed on how this is changing the approach on different situations. So, yeah, we have envisioned that 3D printing will have a long stay here.
you mentioned some of the other specialties. Can you speak a little bit about what those other specialties are?
So we have some cases with orthopedics, craniomaxillofacial surgeons, ENT, so and neurosurgeons. So those were like the most frequent cases that we have. So far, we have worked around 20 cases.
And that's a short amount of time because you basically just started. 2021 wasn't that long ago.
Yeah, it's been a long road, but it's not impossible.
Mhm.
And I would like to also thank RSNA for making us able to learn from you guys, getting access to the webinars and having us to participate the annual meeting, for example. This is a space where we can learn a lot and trying to implement those sort of technologies in our countries.
So having done it and knowing that there are other cities, other countries around you that may be thinking the same way, residents in other radiology programs thinking, how do I convince my attending? What would be your advice or like top 3 things that they can do or they should avoid?
So one of the main problems we have encountered is that many people just don't believe in 3D printing as of this moment. They're just used of seeing the plain films, and they think that this is their way is the correct way. But we have a different approach, and perseverance is another tip, because it's not easy trying to convince these people who do not believe. Also, another tip would be like in one of the talks of Dr. Sommer said, give them a try. And that is what we did. We were talking to many different residency programs and trying to show what we were able to do and trying to convince them. So we offered them a model that we can make in order to facilitate their work. And this is how we started to making some more cases. And soon after that, it was interesting because we used to look for patients. Now they call us and say, hey, can you make a 3D printing model for this patient, please? And that is how we are starting, yeah.
So you got them hooked.
Basically, yeah.
So who was most supportive in the beginning? Was it the people that ended up requesting or the administration?
The people who requested, yeah.
So my other question is, have you thought about presenting your findings and how you started these efforts in, I know in Central America, there's the various congresses. So, you know, the upcoming Congreso Centroamericano de Radiología. Have you guys been invited, been approached? How do you kind of get the word out?
Yeah, so since we are just starting, it's like difficult to promote what we're doing, but certainly I hope so that in the near future we can be invited to these congresses. Yeah.
And for Shayne, obviously you have really looked into the impact of the kind of population that you are serving and seeing how this mix of different payers is influencing the reimbursement and therefore sustainability of the 3D printing efforts. Have you received any guidance, any support from the administration, or have you been able to use this to kind of reset expectations as to what financially a 3D printing lab can do?
I'm gonna have to go with no. We have not been able to reset expectations as far as I can tell. I don't want to speak though for the entire organization on that. We're trying desperately to find areas of funded research that can help supplement the personnel cost of the lab, because of course, in our case, personnel cost is one of the highest costs for the operation of the lab. The next is software, believe it or not, and printers and materials are far below that, which brings up an interesting case, being that the skilled personnel in the software are the most expensive part. It seems that skilled personnel and software would be the highest barrier to other organizations, for instance, like the Alaska Tribal Hospital, Alaska Native Medical Center, a tribal hospital, establishing their own 3D printing center if they deemed there was sufficient need. And I did talk with one of their foundation members about this. We had a phone discussion, a fairly long one, and we proposed the idea of a model where in another center like University of Cincinnati, for instance, or MD Anderson perhaps, or wherever, maybe having excess capacity amongst the time of their people and having the software in place and such could do the segmentation and the modeling and return a mesh model, either STL, 3MF, whatever, back to the other center where it could be printed. And I mean, a Form 3BL installation is quite inexpensive in comparison to just a year of any of the software packages that work as the heart of an FDA type 2 device clearance. I'm not going to mention any particular names, but we know the ones. We know the 3 or 4 out there. So I know that would bring in all sorts of administrative implications and legal liability questions and things like that. But just from a practicality standpoint, it seems that that would be one way to help move the technology out of the large urban teaching hospitals and off into the more remote rural clinics, tribal hospitals, and outside the United States to other areas, into Central America, or Dr. Martinez, you're right that you could support other hospitals in your region with excess capacity with your experience and your software. Because the digital file can be transmitted quite easily. You know, it can be secured, it can be encrypted. There's a lot of things we can do in that area. Moving things digitally is inexpensive, but the skilled personnel to do the segmentation modeling and the CAD work and the cost of that software is probably one of the largest stumbling blocks, I would think, to setting up a point of care center in an underserved area.
Yeah, and I think that brings about a little bit of what we have been speaking on in terms of the work for reimbursement. And you know, you touched upon the difference between a category 3 and a category 1 code and how that may help overcome the challenges in terms of getting absolute 0 to getting at least something. And of course you're contributing to the data by conducting the trial that you guys are engaging in. So all of that is necessary to move the needle forward. And I think we, as members of the SIG, believe in the power of 3D printing in medicine. The question is for all of us, whether we're in a hospital setting or in industry, and that is, if it's not a category 1 code and therefore getting consistent reimbursement, whether we have capacity or not, we might not have the personnel available to engage in the activities. And so if we don't push with the data and, you know, try to facilitate the process of moving into that category 1 code, then the question becomes, how sustainable in the future can these efforts be? Or are they going to basically just stay in big academic centers, you know, like Dr. Gomez, you're in the Capitol, you know, imagine and you had the struggle. So imagine a smaller city that still has all the trauma cases going to them, but maybe receives a little bit less visibility from, the Secretary of Health. Then go even smaller, even though in that smaller hospital, you have the farmers and therefore more critical types of accidents and trauma, that you might argue that might benefit more, right? Because the patient is at a higher loss, loss of income, cannot produce, less resources. So therefore, whatever interventions we can put in, a greater benefit. And so for us in the United States, we are in an insured kind of economy when it comes to medicine. But it's not necessarily the case in other countries. So that's why I think the question is similar, but the approach is different. Like, Latin America should an approach where you have the government really fully support and embrace it through the Secretary of Health initiatives and programs. And then for us, really relying on moving from category 3 to category 1, both achieving the same thing, which is broad acceptance and payment or reimbursement of these services. I think the personnel issue that you mentioned, I think is critical, whether here in the US or anywhere in the world, and that is, I have not found the biomedical engineer factory. Biomedical engineers with this background and expertise, I think, are a precious resource, and I can see why it becomes our biggest investment, because they're really key in this process. So the question is whether it's for industry or for us and at the point of care is how do we sustain those biomedical engineers? How do we integrate ourselves into their training? How do we make ourselves part of that chain? Inviting biomedical engineers that are just doing their early studies into the hospital, and really promote the future of this work, right? Dr. Gomez was a resident, so he's going to be teaching other residents. And so how do we bring in a biomedical engineer student along with your residents? So reaching out to other universities and other facultades, other faculties, especially when we might not be nearby. So I think these are the questions, particularly for the underserved areas, because that's when you can really maximize your personnel cost. It's called your interns, right? You expand your personnel capacity by training and also getting something in return. So Dr. Gomez, I'm curious, do you think you have the capacity? Is the biomedical engineer school close to you guys? Are they able to, jump the bridge and come over?
Yeah, it's a really good question. So, as Dr. Shayne said, our biggest limitation is funding. We have very limited resources, and regarding the biomedical engineering, we actually don't have that career program as of now in our university, but it is available in the private university. So there is a motion to promote or to create the bioengineering here at this university. So we can try to articulate both faculties and make this bigger. Yeah.
So I don't see any additional questions in the chat, and I really want to thank both of you for your presentation and really touching on a topic that influences the practice of 3D printing in medicine throughout the world. And I want to thank the audience that took the time to join us today. And remember, we're going to be recording and posting this webinar so you can access on our YouTube channel. We'll let you guys know when it gets posted on our STIC community site. So once again, thank you to Pedro Gomez Martinez, our doctor representing Honduras, and to Shayne Kondor, our dear speaker from Cincinnati. Thank you to everyone that took the time to attend today, and we'll see you next month on our upcoming webinar. Thank you, everyone.
Bye.
Thank you.